Thank you for all of those for attending today's QI clinic session for the NJAFP and NJIN Echo project. Today's presentation will be the model for improvement and testing. Before we begin, I would like to go through any disclosures. The planners, reviewers, and speakers of this presentation have no conflicts of interest in the development of this presentation. And now for some housekeeping. For educational and quality improvement purposes, this tele-echo session will be recorded. By participating in this session, you are consenting to be recorded, and we appreciate and value your participation. To protect patient privacy, please do not provide any PHI information in today's session. If you have any questions at the end of this presentation, please email us at mweinstein@njaap.org or jsathmary@njaap.org. Please mute the microphone when you are not speaking. On the computer, this can be found on the lower left of your screen. If you are on your telephone, please press *6 to mute and unmute yourself. Please communicate clearly during the session, and please use the chat function to send any messages if you are not comfortable saying anything over the line. Please do not put your phone on hold if you must leave the meeting. We will hear the hold music throughout the presentation. Today's learning objectives are as follows. We will be able to describe the elements of a PDSA cycle for testing changes and apply the use of PDSA to test a change in work. The accreditation statement for today is an application for CME credit has been filed with the American Academy of Family Physicians. Determination of credit is pending. Each physician and clinician must complete the evaluation to receive credit. You will receive an email by close of business today with an evaluation link. I would now like to introduce our presenter today, Fran Griffin. Fran Griffin has worked in healthcare for over 30 years, particularly in the areas of quality improvement, patient safety, and innovation. Ms. Griffin is a registered respiratory therapist and faculty at the Institute for Healthcare Improvement, where she worked for 8 years. Previously, she worked at the CMS Innovation Center and several health systems in New Jersey. Fran works with NJAFP and other organizations on clinical QI programs and is the author of numerous articles related to patient safety and quality improvement in healthcare. Now I would like to turn the presentation over to Fran Griffin. Fran, you are free to begin.
Great. Thanks, Jake, and welcome. As folks can see, we're a very small group at the moment. Hopefully other will be joining us, but for those of you who were good enough to be here on time, we wanted to start by 5 minutes past, knowing that for many of you, maybe all of you, this is your lunch hour, and we will end before top of the hour so that you have time before the afternoon starts up. So with that, let's see if I can get the slides to advance. No, instead, Jake, when I clicked on the screen, it took me out of slide mode. Let me try one more time. There we go. Okay, so we're actually going to start off interactive. I do see that both of the lines connected are muted. So if you would be good enough to either type into the chat or if you would unmute your line to answer a couple of the questions that we have here. So the way these sessions are set up, they follow the sessions primarily geared for the physicians and the clinical staff that occurred the day before. So we had one yesterday talking about standardized protocols to help improve vaccination rates and inform patients about vaccination options and risks and things like that. And so today is the following on the QI session, which is, so of course, open to all of the physicians and clinicians, although we're expecting to get more of the practice staff. Since there's just 2 of you on here, it would really be helpful if you could type into chat and send it to everyone, or unmute your line and let us know who's on the line. So what's your role in the practice? If you've got multiple people who are listening in, it would be great to know that. So that way we know that whether there's 4 of us or whether there might actually be 5, 6, or more of us out there. And you can unmute your line by taking your mouse to the lower left-hand corner of your screen, and you should see the options for the microphone. If you prefer not to unmute or it's not working, then please type into the chat and send to everyone. And it's just two connections, so we'll wait for you. The first one is Jay Fiorel, and the other one is Jana Park. That's the way it's spelled on Zoom. Jake, can you, wait, we got, okay, the first one, thanks. Jane Park, thank you. Family medicine, okay, second year resident at Hackensack Palisades Hospital. All right, great. And Jane, are you by yourself today or is anyone with you? Just you. Okay, great. Thanks for chatting in first. And if we could hear from the other person, I don't know, Jake, can you try to unmute them in case they are unable to unmute themselves? Okay, the line.
Hi, this is Jackie Fiorillo, the Director of Nursing at the Community Health Center, and Lois Fantone, who's the Director of Quality Care Management at the Community Health Center.
Great, thank you so much. Glad we got your line unmuted so that we could hear from you. Again, we're a really small group at the moment, so we're gonna keep it very informal and interactive. So as you probably know, if we want to improve, we've got to make change. It usually does not result in a different outcome. So if you're working to improve vaccinations for the patient populations that you see, and the rates are not where they need to be, then chances are you're going to need to do something different. So what we talked about yesterday on the physician-oriented call, which you may have been on or not, you can type into chat and let us know if you were not. I'm going to assume right now that maybe you were. We talked with the physicians who are on about protocols and the use of standing orders and protocols for either administering vaccines in the practice setting or for collecting information, because many patients get them outside of the practice setting, pharmacies being a very common place. And we, at the end of the call, we asked everybody who was on the line, who's participating in this project, to think about one change idea that you might try to improve vaccinations and possibly through the use of protocols or standards. So thanks, Jackie, for noting that you and Lois were not on yesterday's Zoom. It was recorded, so you can always go listen to it if you like. But in general, what we did was we talked about how protocols and standards reduce reliance on memory. They ensure that everybody's doing the same thing. Standing orders for giving vaccines are recommended by the CDC. And if you're not giving the vaccines, you can certainly use protocols or standing orders to assess patients, to educate patients about their concerns about getting a vaccine, perhaps have a protocol with a pharmacy to provide you information on patients who may receive them, et cetera. So hopefully you've had a chance to talk with whoever was on from your organization yesterday, because that's what their to-do was, about a change that you might test, because then what we're going to talk about is how to test. And basically by a change, we mean something that you're not currently doing, or something that you would be doing differently, or something that you will stop. So you can both feel free to type into the chat if you like. Have you talked about a change that you might do locally? If the answer is no, that's okay. It would just help me to know that, as I'll adjust the direction I take these slides based on your answer. So Jane, I'll start with you first. Again, since we're a small group, we're going to, oh, did we lose Jane? I can't see the full participant list anymore. Okay, thanks, Jane. Okay, did not get to talk about it yet. Jackie and Lois, how about you?
At this point, Fran, we're not planning any specific changes. So.
Okay, so I would encourage both of you to, and by both of you I mean Jane and the Jackie and Lois group, Think about something, particularly around the use of standard approaches, protocols, standing order sets. Maybe you're already using them. Are they working? Are they not? But think about something that you might do differently. If you've got data on your vaccination rates, and I've got some data that has come in as part of the baseline data, what I've looked at so far shows tremendous opportunity across all of the vaccines that we're looking at. So whichever one you feel in your organization or practice you want to work on, start thinking about what might you do differently. And so thanks. Somebody just typed into chat. Looks like we've got a few more people here. That's great. Improve your standing orders by education of staff. So I'm going to encourage you to think about something beyond education. So if you can see the slide on the screen, when we talk about change, we're talking about something you're not currently doing something differently, or stopping something that's just not working. So education is certainly incredibly useful. Education, though, is usually not a change. And there's great examples that we've all experienced of where education doesn't work well for achieving improvement. So it's fundamental that people have education to understand what they're supposed to do. But education typically doesn't result in sustained improvement, because if the process isn't working, it's usually not because people don't know what they're supposed to do, and educating them isn't going to make the process work better. So think about the process. So a lot of what we're going to talk about throughout this whole year of this project is changing processes, because education doesn't work if the system just isn't designed to achieve the results that you want. So that's why we have to think about changes. So if you have standing orders and people aren't using them or following them, chances are it's not an education issue. The standing orders might not make sense. They might be outdated. They might not be accessible. So think about all of the potential things that result in people maybe not using the standing orders. It's usually not an education issue. What we see happen with education, and I used to do this when I was first in quality in the hospital setting, we educate people and the data gets a little bit better for a short period of time. When the education's over, it slips right back to where it was before. And then we go out and we do more education, and we put posters on the wall, and we do things to kind of remind people. The data goes up a little bit, and then it goes back to what it was before. And we just get stuck in this circular pattern of educating and reminding and getting blips in data only to go right back to where we were before. And the reason that happens is we have to change the underlying process. So we'll talk a lot as we go through this over the course of the program about what do we mean by looking at process. Think about a change and think of that as being an action-oriented thing about the steps that people do, not education. Okay, Jake, I don't know what is going on here, but every time I try to advance the slides, it takes me out of slide mode, and I don't know why.
Try again, Fran.
Okay, that time it worked. We'll keep our fingers crossed. So, we're going to use the model for improvement. So, some of you may already be familiar with this. If you are, this will be hopefully a little bit of an update. Maybe you'll hear something new. But the model for improvement is how we're going to frame what we're doing. So if we want to improve, and the goal of this project is to improve vaccination rates, then we have to think about three things. And the model for improvement was created by Associates in Process Improvement. Their website's down in the corner, and you have access to all the slides if you want to read more about it. But basically, the three questions at the top are how we get started. First, we define what do we want to accomplish. We set a goal. Secondly, we then think about how will we know changes are leading to improvement. And that's all about data. There's only one way to know if things are improving, and that's to measure. Then we look at what changes can we make that might result in improvement. And so when we think about changes, then we'll think about using PDSA cycles to test those ideas out. And so I'm just going to go through a little bit of why. So when we apply the model, how do we set the framing for what it is we want to accomplish? First, we develop an aim statement. If your organization or practice hasn't done this yet, I would encourage you to do so within the next week. We were going to do this at the kickoff meeting last month, but due to some challenges with attendance we adjusted the plan that day and instead sent that via email. So hopefully you all received the email indicating that you should set an aim with a document from the Institute for Healthcare Improvement with some tips on how to set an aim. I'll talk about an aim in a moment in case you haven't looked at that. But you want a goal. Figure out what vaccine do you want to improve, by how much. You don't have to work on all of them. You might choose to work on one, you might choose to work on 3. That's entirely up to you and should depend on the resources you have available and what you think is realistic. And how will you know that a change is improvement? Well, you're going to measure. And we have a website that many of you have probably already been oriented to, where we're going to have you put your data so that we can learn with you and see what is improving and where the direction is going. And then when we think about changes, there are a couple of things we can do to frame out the changes. One is we can develop something that's called a driver diagram. That's a visual layout of all of the things we think are necessary to achieve our goal, helps organize the project. One piece of paper, usually totally adequate for this, and then use PDSA cycles to test, which is what I'm going to focus on today. So when we define an aim, we want a very clear goal or objective. And we want to state it in quantitative terms. We're going to measure it. We want it to be very specific. We want it to be measurable. And most importantly, we want to put a date on it. We want it to be time-bound. We're answering the question, how much improvement to what, for whom, by when? It's really important to do this before you start an improvement project because, as the quote at the bottom shows, if you don't know where you're going, any road will get you there. So you can't really think about effective changes and start testing them unless you first define what it is you want to accomplish. And everybody in the practice really should be involved in this because it works best when it's a group decision and not when it's handed down from somebody else. So again, if you haven't done that yet, I would encourage you to do it. It doesn't take a lot of time. If you've got an existing meeting where the staff all get together, take 10 minutes out of that meeting and talk about an aim. If you want feedback on your aim, I'm happy to provide that. But let me give you an example. So what if I said that this was my aim? I would become healthier by losing weight. Well, it's pretty vague, not really measurable. What does healthier mean? And also, if you notice, it has no time frame. So okay, I will become healthier by losing weight. It doesn't even sound like a strong commitment, does it, when you see it framed that way? But if I were to frame it using criteria for a good aim, I would have something like this. I will reduce my weight by 20 pounds by December 31st. You can see this is from 2018, but I could easily make it 2019 and it worked very well. Anybody reading that or hearing me say that knows exactly what I'm trying to accomplish. It's very specific, 20 pounds. I could also put BMI, I could put kilos, it doesn't matter, but it's measurable, it's got a number, and it's got a date by a very specific date. The advantage of an aim is not only does it give clarity for everybody who's working on it, but it also helps create a little bit of a sense of urgency. So we would encourage an aim that's not 5 years out because people don't really feel a sense of urgency. But when you put a stake in the ground, then you feel that sense of urgency to work on it. So what we look for in an aim, there we go. We want it to be SMART. And SMART means it's specific, it's measurable, it's actionable. We want something we can do something about. We want it to be relevant and realistic. We don't want it to be so ridiculously grandiose that there is no way we will ever achieve it. That's deflating for the team. But we also want it to be a little bit ambitious. So if I put I was going to lose 2 pounds by December 31st, that would probably be pretty weak. I could probably accomplish that in 1 week, let alone till the end of the year. And so we don't want something that's so easy that it just doesn't make people feel like it's going to require much energy. And we want a date. A specific date really does help with that sense of urgency. So once we've identified what we want to accomplish, then we have to think about how are we going to get there. And a lot of the improvement science comes from Deming, and he had this quote, "Information is not knowledge. Let's not confuse the two." So we need to generate some new knowledge if we want to see improvement. Data is not knowledge, it's information. So if you collect data on your vaccination rates, that's information. It's not knowledge because it doesn't tell you why the numbers are like they are. So if you want to generate new knowledge, you've got to test. And actually all of us in school, when we learned the scientific method, back even to high school, and those of us who went through graduate training probably got even more of it, especially those of you who went through clinical training, we make a hypothesis and we test. Well, improvement is pretty much the same way. And the reason I have this picture of this cute little kid here is we've all seen this happen when we've watched a toddler learn how to walk. So if you have kids or nieces or nephews or friends with kids, we've all at some point watched a little kid try to learn how to walk. And what they do is really PDSA over and over and over again. They think about what they're going to do. They try it out. We know it doesn't work for the first probably 100 times because they fall many, many times before they get a few steps in a row. And then they ponder on what they did, and then they try again. And they're actually doing little PDSAs over and over and over again. We need to apply that same methodology to bringing a change into the work you're doing in the practice. So don't identify a change and then just say, starting Monday, we're all going to do it this way. Because if it's not the right fit, or if there are things that you haven't thought of, it could create a lot of disruption in the work and make people really unhappy. But if you test it out, you can learn very quickly whether or not it might work in your practice without causing major disruption. So the reasons for testing are to increase belief that the change will result in improvement. Sometimes we're not sure, or sometimes I'm the person who brings in the change. I'm very, very sure, but the other people around me aren't convinced. So doing a few tests helps them see, oh yeah, this actually might be a better way of doing this, or this might help us achieve the goal. So we can predict what we might get from that change. We also can adapt it. So if I just go back and I look at who was on the early part of the call here, you know, we had somebody working at Hackensack Meridian and Palisades Hospital, and now we've got some other folks from some other practices. Your environments are different. So how it works in one organization may not be exactly the way it's going to work in another. So by testing it, you can say, yeah, you know what, to make it work here, we probably have to adjust this, or we have to include that. That's what testing allows you to figure out. It also makes it easier if people are resistant to the change, because once they see on a small scale that it works, then they're a little more receptive to it. So this is the PDSA cycle. If you're not familiar with it, these are the details. It's also known by the other names in the lower left-hand side because it's been attributed to different people. But the general idea is that you've got 4 equally important steps. That doesn't mean that they each take the same amount of time, but they're all equally important. So we always want to come up with a plan. We might come up with a plan in 5 minutes or something we want to test. And then we want to test it out by doing the plan. And then we will study it, figure out what did we learn, and then in the act phase, we figure out what next. So sometimes what happens is people see the PDSA cycles and they think, I don't have time for this. I am too busy and this is going to slow me down. The reality is that when this is used in a small, simple way, you can actually learn very, very quickly, and a cycle could take 10 minutes depending on what you're testing. Let me give you one quick example. When I was still working in the hospital setting, we had identified some changes we wanted to make for our outpatient registration process. It was mainly people coming in for pre-admission testing. And we identified some changes that we thought would help move patients through the registration process faster. So we came up with one of the changes, and we asked one of the registrars to try it once. First person of the day, try it one time. Now, most people will try something if you say just once. Again, those of you with kids, it's how we get little kids to eat. I've done this with my nieces and nephews. Try it one time, and if you don't like it, I'll never make you do it again. Well, the same thing is true with testing. Ask people to try it just one time, not change the way they work, and get feedback from them. So we had the registrar try it with one patient, first patient of the day, and as soon as that patient went through and went on to the next phase of the process, we talked to the registrar to see how it went. We were timing how long it took the patient to go through, so we knew it was indeed faster. But what we learned very quickly in conversing with the registrar was that she absolutely hated it. I don't remember now, because it was a long time ago, what it was that she didn't like, but I do remember that she didn't like it at all. And that meant she wasn't going to do it again. But what we asked her for was, okay, what didn't you like? What might you do differently? She had some good suggestions. If we come back and we adjust this, would you be willing to test it again tomorrow if we make some of these adjustments? And she said yes, and she did. So our plan was, we got with the registrar ahead of time and said, here's what we'd like to do. We'd like you to do it with one patient. Figured out who, what, and the whole plan. The do took about 10, 15 minutes perhaps, because it was just having the patient go through the process and doing something different. The study took about 5 to 10 minutes of us conversing with the registrar to find out how it went. And then the act was figuring out, what are we going to do differently since this clearly didn't work? It all happened in under an hour. And we were able to then go back and test, and we just kept repeating that process until we had something that worked. And so you can do things on a very small scale, very quickly, and learn a lot. And it was so valuable to do it, because if we had just rolled out that change, it never would have worked. Registrars wouldn't have liked it. And if we had just said, look, do it this way, they would have been reluctant to try again if we came up with another change after that one bombed, which it would have bombed. So we got a great deal of value out of taking the time to do that small scale test. So the strategies for small tests are, make them very, very small. I like the rule of one. One nurse with one patient, one time, on one shift for one day. That's all you need to start. Always start with the willing. Don't use testing as a way to convert people who aren't into this whole thing. Don't try to get buy-in from everybody or get consensus. If you've got one willing volunteer, that's really all you need. If the other folks aren't on board, let them wait and see what happens with testing. Use simulation, especially in patient care. Sometimes it's better to simulate by doing a dry run or just going through a what-if scenario. Ensure that you test over a wide range of conditions. So don't test everything on weekdays if you also see patients on weekends. If you've got different shifts, make sure you test with them and include all departments that might be affected if that's applicable. And think ahead. Think, if that works, what will we do next? We want to collect just enough data to learn whether or not our test yielded what we were looking for and what did we learn. We're not trying to do a research project that we're going to submit to the New England Journal of Medicine. We're not doing a formal evaluation to send to CMS or the Joint Commission. So we just need a little bit of data that answers the question, what did we learn? Pencil and paper is fine. And sometimes that's all we need, because we don't need to go modifying an information system for a test. In fact, we probably don't want to put in a modification to the information system until we've tested it out first and figured out how it's going to work. I have a colleague who says, if you can't do it on paper, don't do it in vapor. Because sometimes if you submit a request to IT and then you go back and change it 5 times, they start to get a little irritated by the frequency of the requests. Sampling is fine. So we're doing some other work right now with some practices that are working to identify patients with prediabetes. And we've asked them to collect data on the first 10 patients who come through. Not the whole day. You don't need the whole day. If you collect it for the first 10 data points is enough. The qualitative data is equally important to the quantitative. The registrar telling us that she hated it was as valuable as the cycle time it took for the patient to move through. And make sure you capture what you didn't expect or what might have gone wrong. So this is kind of a summary of things that I've said throughout the last few slides, but you want to make sure you do all 4 parts of PDSA. People so often go right to the do and skip the other parts. They're all really important. We just want to learn enough about, should we try this again? So the rule of 1 in the shortest possible time is a good way to go. If you're in an organization that has hierarchy and committees and executives that have to approve, ask for approval to test, but not for every little iteration of the change, because that will just slow you down. And that way you can come to them after you've done enough testing to say, this is the form we really want. You might go through 10 versions of the form before you're ready to say, this is what we want the form to look like, or this is what we want the screen in the electronic health record to look like. Make sure you study right away, get that feedback immediately after. And if you have the resources to do it, test several changes at the same time. You could have one person testing one approach and another testing a different approach, or testing something completely different. By keeping it small, you can do a whole lot. So we start off with a theory or a hunch that making this change is going to make things better. It's going to help us identify people's vaccine status. It's going to get our vaccination rates up, whatever it is you're trying to accomplish. We start very small, and then as we learn, we get bigger and bigger. So we go from one patient with one nurse to maybe let's do it with all the patients for a day. That worked. Let's do it with all the patients for a week. Let's try it for a couple weeks. And we ramp it up until we've done it enough times that we feel really confident that this is a good change. It's going to lead to improvement. Now we're going to make it permanent in our work. We're going to implement that change. So how do you integrate it into a project? Well, one thing you should do is document. It doesn't have to be fancy or sophisticated. Using a form like the one pictured on the right can help you think about all of the things to consider when you're rolling out a change. A copy of that form is available on the Simple QI website that we're using. And just make sure you capture what you learn. In the early phases of doing PDSA, these forms are great because it really helps embed the process in your mind. And then remember, we're testing to learn. It's not to prove that your idea is right. Sometimes we learn with a test that the way we were going to go about it is not the best way to do it. We want to avoid confirmation bias. So look for things that indicate maybe it didn't work as we thought. Make sure you listen to the naysayers. And making the tests very visible so that everybody's aware of them can really help with not only getting feedback, but also for other people who may be a little resistant to the idea. People are often afraid of change. It's kind of wired into us as human beings. So let me pause there. I see we've had more people join us while I was going through the slides, and see what questions you have, if any. But before we get to the action item, any further thoughts on a change that you might test? I saw early on that a couple of you were thinking about education, and I'm really trying to persuade you to think about a process change, changing a step in the process rather than education about the existing one. Has anybody thought of anything as we were going through this that perhaps you could chat with your colleagues in your practice about possibly testing? And again, if it's related to standardized approaches like protocols or standing orders or other types of things, that would be great, as that segues with what we were talking about yesterday. And please type into the chat and send to everyone, or if you're comfortable, you can unmute your line and speak over the phone. We're not a real large group or computer. So this is where we build interaction for folks. So I see, I don't know the name. The last message in chat was M20095, creating a flyer or a reminder card for staff to remember using a standing order. So that's an interesting idea because reliance on memory is a really bad thing. I am living testament to that. Thankfully, Google and Outlook have both figured out that if I use the word attached or attachment, that means I probably do want to attach something to my email. Prior to that, I used to regularly send emails out with long descriptions about attachments that I never remembered to attach to the email. And then I get emails back from people, no attachment, no attachment. Now Google and Outlook, I get a little pop-up. If I use the word attached or attachment and I forget to attach something, I'll get a little pop-up. I intend to attach something, and it's more than just a reminder, it's actually a forcing function because I can't send the email until I answer the question. I have to, because sometimes I'm referencing another attachment somebody sent me and I'm not going to attach something, and no, I'm not looking to include an attachment, but I have to tell Outlook that or Google before I can hit send. So it's a forcing function. It's a little bit different. So for whoever M20095 is there something else that you might do if people are not remembering to use the standing order? Is there something else that you could do to build that in to the standard work? Where is the order kept? How do they access it? Is there some way you could make it more consistent without having to create a reminder?
Hi, this is Dr. Morzami. Can you hear me?
Yes.
Okay, finally. So, yeah, I explained yesterday that we have protocol as a standing order and also pre-visit checklist. But, and when we did the RCA, we realized that the main reason that people are not using it, it's, of course, because they have too many things to handle and they forget using them. And we had a brief meeting yesterday after our noon meeting, and we came up with a few suggestions from our residents. One of them was to create a reminder, like a reminder card or flyer in each nursing station or triage station, so the staff can remember using their standing order. And also doing similar thing in our EMR.
Great. I'm so glad that you had a follow-up discussion after yesterday's session. So that's really great. I would encourage you to think about, because you hit on something that was really key in there. People are forgetting because they have so many other things to do. Sometimes the list of things to do just grows over time, and it becomes valuable to sit down and say, let's take a look at the list. Do we still need to be doing everything on this list? Or do we need to be doing it at the same time? Because maybe people are doing something that they've been doing for 10 years because nobody ever told them to stop, and it's not value added anymore. Just a possibility. Reminders tend to work for short periods of time. If you walk around in organizations, I remember this used to be true when I worked in the hospital. And even when I was on an ambulance squad for a while, we had reminders on everything. And they became part of the wallpaper after a while, because when the reminder is first there, everybody notices it. But then after a while, it just becomes part of the background scenery, and we don't even notice it's there. So if we're putting a reminder in, think about that as a possible flag to let's look at the process and how we can make this an automatic part of the work, so that a reminder is not even necessary. I try to remind myself to take stuff with me by putting it next to the front door, so that when I'm going out to my car, I pick it up and I walk past the stuff, even if I put it next to the front door. I learned last year that I shouldn't put my phone down on the roof of my car when I'm getting in. Our brains just are wired that when we're busy and distracted, stuff goes out the window. So think about, is there something else you might do in the long term? Maybe a reminder will be good for the short term, but in the long term, will the reminder work? Maybe the process could be changed in such a way that people don't have to remember, that it's, you know, built in or somehow attached to another piece of work. All right, thanks for sharing.
Right now, we have a vaccination tab in our EMR. But again, it's another step for physician and staff to open that tab and check that.
Yep.
So having a box in the review when you are starting patient or at the end of the visit, which basically like a small note about like, did you ask patient about flu vaccine, or did your patient have a flu vaccine? Something like that would be helpful.
Yep.
As you know, usually quality, to stay up to date with quality metrics, EMR usually helps with this kind of measures. But I actually even spoke with our IT department yesterday, and that's not something possible. Like, we can't create something in our EMR for a test. It's actually beyond our control.
Right. Yeah.
Um,
EMRs are tough to change because there's usually so much involved with that. Are you using pre-visit planning for patients who are coming in?
Yes, we have a pre-visit checklist that we use to update vaccination and quality.
Yeah, so that's one way that some places have done it. And also thinking about who's the best person to ask the question the first time. So by the time the patient gets to the physician, they may have seen a couple of other people in the practice, whether that's a medical assistant or a nurse or somebody else. And is there somebody else that could ask that question earlier so that by the time the patient gets to the physician, that information has hopefully been captured and the physician doesn't have to remember to go to the tab because it's being moved to a different part of the system. So things like that are sometimes the strategies that people use to try and move the work to another part of the process, as opposed to putting a reminder on a process that's clearly not working.
So the staff are the first line when they do check-in. It's usually a nurse or MA that they do the vital sign, medication reconciliation, and depression screening and fall assessment. And again, our standing order are supposed to be used at that stage. So we have a standing order. I mean, we can improve the process by educating a staff about immunization. And I heard you said that cannot be a change, but if the staff are not using it, I guess we have to find a way to make them to use it.
Yeah, so the key there is, your question is spot on. If they're not using it, is it because they don't know about it? Is it because they don't know about the importance of it? So education could be beneficial if that's the reason they're not using it. Most of the time when a process is not working, it's because of the way it's designed, as opposed to the knowledge of the people in the process. Education sometimes gets, like I said, that little brief increase, but then things go back to the way they were before because the process itself has remained the same. So it's worth digging into, try to understand why is it not happening and what could we do differently, rather than remind or educate people to keep doing something that's clearly not working as well as you would like. In the interest of time, I'm going to move it on. Thank you so much for sharing. I want to make sure you've all got plenty of time to get back to your schedules. So just a little summary slide on the model for improvement. Model for improvement is the 3 questions that you see: setting a goal, thinking about what you'll measure, and identifying changes, and then using PDSA cycles to test them. Remember, there are 4 equally important parts. Doing this on a small scale is absolutely the best way to learn quickly so that you can make improvements to your data on your vaccination, make changes that will result in improvement. I've included a bunch of references here if you're interested in further information. Some of them are books. There are also websites for both Associates Process Improvement and the Institute for Healthcare Improvement with lots of information as well. So we do want to make these action oriented. So between now and the November session, what we're asking all of you to do is conduct at least 1 test cycle of a change using PDSA. Now, since I mentioned a test cycle could be done in 5 to 10 minutes, that should be very easy. Ideally, make your plan today while this is all fresh in your mind, if time permits. Consider using the form. It's on Simple QI. I can email it to you if that would be helpful. Just email me. My address is at the bottom, or you can email Jake. But consider using the form for the first few times that you do it. We'd like you to really think about if you can do a test cycle by Tuesday of next week. And remember, keep it really small. Even the word small is small. Keep it really small. Try something with 1 patient coming into the office or 1 person in the office. Discuss what you learned and determine what you'll test next. And if you can, between now and the next session, try to run multiple test cycles. The ideal, if you've got the resources to do it, would be to have at least 1 a day, 3 to 4 a week. That would help you learn really, really quickly, and you'd probably have results by our next session. On the November 20th session, please do come prepared to share what you did, how it went, and what you learned. We'll be a lot more interactive on that session because we'll hopefully have a lot for all of you to talk about. And if you need assistance or you have questions between now and then, my email address and phone number are here on the slide. And I'll leave that slide up because we are at time, and I'll stay on in case anybody has any questions. For those of you who need to drop off, thanks for joining us today. Have a great day, and I look forward to hearing what you've done on November 20th. Thank you. And for those who are still on, if you have a question, feel free to call it out over the line or type it into the chat. And the rest, if you need to drop off, please feel free to do so.